And thank you very much. First of all, I would like to thank the organizing and scientific committee to give me the opportunity to present our work, fatal intracranial hemorrhage in acute promyelocytic leukemia with short isoform of PML RAR alpha. And we try to review our molecular and radiological data. Next slide, please. So I will briefly talk about the rationale, the introduction. Next slide, please. Introduction about PMR alpha. So actually the basis of our study started within observation of early mortality in patients with short isoform, which is called as BCR3 of PMRR alpha, even before treatment commenced. So based on that observation, we decided to review all the available cases at that time for the morphological, clinicopathological, and radiological features in order to see the outcome of these patients in relation to PML RAR alpha isoform expression and diagnosis and follow-up. Next slide, please. Now, as you are aware, PMLR alpha fusion transcripts result from a chromosomal translocation T1517, and this is a molecular hallmark of APL. And PMLR alpha occurs in 95% of APL patients, culminating the differentiation block at the promyelocytic stage. And in KSA, leukemia incidence is about 6.2% according to the cancer registry, and globally, APL accounts for about 10 to 15% of AML. Next slide, please. Now, there are some advantages in APL, not really from the patient perspective, but in terms of the outcome we have. As you know, the targeted therapies are available for ATRA and arsenic trioxide, which has really led to greater than more than 90% survival rates in APL. Then we have advances in supportive care, and that has really improved overall survival and disease-free survival in APL patients. In addition, we have technological improvements recently in molecular diagnostics and monitoring that has been instrumental in improved outcomes in APL patients. Next, please. But there are certain disadvantages as well, right? One of the disadvantages in terms of outcome is intracranial hemorrhage leading to early death before even commencing the treatment. That's an unsolved complication. As you know, bleeding is an complication in APL. And in addition, we have really no systematic clinical and laboratory data analysis in APL that has addressed these issues. And in APL, as you are aware, 10 to 20% of APL cases have relapse, irrespective of their risk status. And another problem is differentiation syndrome, which could lead to pulmonary infiltrates, embolism, long QT, and other associated infections. Now, here this slide shows you the exon map showing PML and RAR alpha genes that are involved in the chromosomal translocation in APL. As you can see here, PML gene with 9 exons, E is the exon, and RAR alpha with 10 exons. Based on the breakpoints we have, as you can see here, the generation of break, wherever the breakpoint we have, it leads to the generation of either the long form of the PMRR alpha, which we call as BCR1, and or with another breakpoint, which leads to the generation of short isoform of PMRR alpha, which is called as the BCR3. And these we can detect or monitor these isoforms by either cytogenetic, FISH, and karyotyping techniques, which in most of the cases detect all, in theoretically, all the isoform of PMRR alpha without specifying the isoform. And the molecular techniques, of course, cannot detect all, like cryptic translocations, for instance, but it will specify the isoform we are detecting. Next, please. So here, the next slide shows you some data from KFMC for FIBA for patients, FISH and qPCR results whenever there is a morphological indication. As you can see on the left panel, morphological indication of acute promyelocytic leukemia. We go for FISH analysis for PMRR alpha or karyotype analysis, and qPCR, as you can see on the right panel, qPCR was performed for the detection of BCR3, the short isoform, and BCR1, the long isoform. You can see these nice RGP curves, these growth curves with the low positive and high positive. In the middle, you will see BCR3 and BCR1 and ABL as internal control. Next slide, please. So now the question here is, how do clinical labs report PMR alpha? Our lab is a molecular genetic lab. So how do we report it? Now, whether it's a cytogenetic and molecular lab, all the labs report either detected or not detected, positive or negative results. With molecular labs, some more reporting also some value, CT value or normalized copy number value of the fusion gene to the control gene. And none of these labs, in fact, report the isoforms detected, whether it is a long or short isoform, probably because of the reasons which are mentioned here. Clinical relevance of major isoforms is inconclusive. There is conflicting data about prognosis, some suggesting poor and some suggesting good prognosis in BCR3 then BCR1 isoform, and also association of PMR alpha isoforms with pre-treatment hematological parameters. But there is no change in the treatment outcome of patients, whether you have BCR1 and BCR3. So these are some of the reasons why labs do not report these isoforms. Next, please. But if you see our data, so we analyzed our PMR alpha data, and here this slide will show you overview of the clinical data we have. So we had a total of 21 patients, of which 8 patients, 38% were BCR3 positive with the male predominance. As you can see, male-female ratio of 3:1, and BCR1, 13 patients of BCR1 with 62% rate. So and I have highlighted here 4 boxes you can see. These were the BCR3 patients who unfortunately died early. So there was high mortality even before starting the treatment. That's why I have highlighted them here. And as you can see, most of these BCR3 patients were high risk according to Sun score, greater, WBC and platelet count greater than 10,000. So next, please. So here you can see of these BCR3 patients, 8 BCR3 patients, 4 of them, as I said, died early, showed early mortality, and the rest of went into molecular remission, and none of the BCR1 patients died, and all went into molecular remission. And as you can see in the right panel, the qPCR results, all of these patients who died early, BCR3 patients, were actually BCR3 positive. BCR3 positive. So as you can see here in this diagram. And next, please. Yes, I will go quickly. And as you can see here, this results show the radiological pictures, radiological data of our patients. And what we observed was that BCR3 patients with BCR3 isoform of PMR alpha have intracranial hemorrhage, as you can see in these with arrows here. Next, please. This was not found in patients with BCR1 isoform. Next, please. So again, molecular monitoring results also showed that BCR3 patients have a prolonged isoform expression. As you can see, with treatment post induction at day 28, you can still see BCR-able, and even at day 60, we have the presence of BCR3. While as in the BCR1 patients, at day 28, they go into complete molecular remission. Next, please. So extended molecular monitoring results also showed earlier reappearance. Although the BCR3 the patients went into BCR3 patients went into complete molecular remission, but the reappearance was very quick, with 2.5 years, 1 year, 1.5 year, and so on. While as in BCR1 patients, there was the reappearance was very late, 9 years, 10 years after. Thank you. So next, please. So these here show the differential outcome of our patients. As you can see, with respect to some of 4 of these patients died early, while as others are alive, and all the BCR1 patients are still alive and still being monitored in the lab. Next, please. So this also shows, I mean, possibly the patients with BCR3 had acute kidney injury. That's why you can see the results of creatinine very high in these BCR3 who died early, while as BCR3 and BCR1, those who are alive, had no effect. And the percentage probability, of course, of the overall survival is very much reduced when we have BCR3, whether taken independently or dependent of each other. Next, please. So in conclusion, yes, in conclusion, selective PMR alpha transcript expression in AML patients may not be a random event, but impact disease course over time. And this data raises the possibility of incorporating PMR alpha isoform expression at diagnosis into APL risk stratification system. This is very important, I think. And the use of CNS prophylaxis is implicated. And clinical laboratories need to devise standardized reporting methodologies for PMR alpha isoform expression, and not just report detected and not detected, as is the current practice. Next, please. Last one. So now whether the take-home message is that whether these PML alpha isoform expression, that's important, isoform expression at diagnosis should be incorporated into risk stratification system and use of CNS prophylaxis to prevent these early thrombohemorrhagic death. This remains an open question, and we would like to have more data from the kingdom to see how this, if this hypothesis in fact holds true. And lastly, I would like to thank the authors who participated in this work, and thank you very much for your attention.